Yeah, we're just about to see.
Is the screen visible, sir? Yes, sir.
Yes, sir.
Okay. Thank you, Tarun sir. As the time is short, I will directly go with the talk. Um, Basically, I just wanted to share and sensitize the current scenario. So, so we'll be speaking about the general profile of undifferentiated tropical fever, what we have, and this is the season for scrub and dengue as well. So I'll be emphasizing on what the consensus guidelines on for the empirical therapy of undifferentiated fevers. And we'll be looking at the clinical spectrum of scrub typhus as well in our region because it has multiple facets. At one time, it used to be syphilis, which comes in different kinds of presentation, and then it used to be HIV. So, and now we have even corona, which is having multiple presentations. Like lately, some patient presenting with mucormycosis following corona. So something like that. Scrub also has various facets which we should be aware of, and uh, and the major blockade is the point of care testing. As the point of care testing is becomes more readily available, something like a whole blood clotting time, which we can just do it on arrival of a patient at the bedside, we can make a decision. So that makes a difference in clinical management at the primary care physician level. In hospital settings, many a times it is available, but in primary setup, this is what makes many of the patients going undiagnosed. And finally, this is what the recently coming up as antibiotic responsiveness. We have seen that the response to antibiotics is slightly changing compared to the reported literature. So that also I would like to emphasize today. So just to start with, this was large scale. There are two large scale studies done across India in multiple ICUs. This was done with from PGH Chandigarh as the leading point. There's another study with Vellore as a leading point, where they have taken 34 ICUs in India, and with a good with most of the patients have been quite sick enough that the mortality is at almost 18%. So what they have found is throughout the year, dengue and scrub typhus have been the predominant uh, febrile illnesses which have been affecting the children, especially in the winter, in the rainy seasons. Then comes the meningoencephalitis, malaria, leptospirosis, sepsis, and pneumonia. These are the top things we'll have to consider and work up. And there was a time when meningoencephalitis presentation was almost always Japanese encephalitis, but over the years, as the reports of scrub typhus built up, even in the northeast area and Assam, Bihar area, previously, it used to be undiagnosed encephalitis syndrome. So later, people realized that it is a scrub typhus. So this is a story which has evolved over the last 20 to 30 years. So this is the recommendation of the critical care medicine guideline consensus. So it is better to have a syndromic approach when it comes to undiagnosed or undifferentiated tropical fevers. So we are all aware dengue and thrombocytopenia is like its layman's terminology. So whenever you come across a patient with a falling platelet count, it need not be just plain definition of thrombocytopenia. Falling platelet count from the previous value. You think of dengue scrub. In our area, malaria is almost, less reported, I would say, or less diagnosed. Leptospirosis is also to be taken into consideration. So in the particular study, thrombocytopenia was seen in almost all patients with dengue and in 60% of patients with scrub typhus. So, but most often in our experience, we find that many of them come with a respiratory presentation, an undifferentiated fever with some cough and cold and mild tachypnea and tachycardia. We don't have much lung findings on chest X-ray or on clinical examination, but we have a supportive thrombocytopenia or organomegaly. We strongly think in terms of scrub typhus, malaria, typical and atypical pneumonias. This picture, atypical pneumonia also we think of. So in the setting of renal failure, just azotemia is there, patient is sick looking, think of scrub typhus, leptospirosis, and dengue and malaria because all this compromise circulation as well. And the common presentation is encephalitis syndrome. In children, especially, if we take then even in our setup, apart from Japanese encephalitis, this is one of the equally important organism, and many setups in Northeast India, this is the most common cause for acute encephalitis syndrome. So much so that there is empirical inclusion of anti-rickettsial medication also in children presenting with encephalitis. I'll come to that later. So then fever and jaundice, most often it is viral hepatitis. Fever and MODS, most often it is sepsis. Sometimes scrub. So that is how it is. So when it comes to empirical therapy, again at the community level, um, it is better to have this syndromic approach, and as much as possible when we can get the point of care. I'll be talking about the test as well. Point of care diagnostic test for dengue, malaria, and typhoid. We are almost sure what we are treating most of the times. So the recommendation at that point is ceftriaxone and doxycycline in a child with undifferentiated fever. You have waited enough for 4 to 5 days to 7 days for, let's say, thinking there is nothing at all in the blood counts, nothing at all in the clinical examination, no Eshkar as well. So it is justified in an endemic area during the rainy seasons to start doxycycline as well. Acyclovir is as by recommendations in a child presenting with encephalopathy. Coming to encephalopathy, we don't have time to wait and watch. So we always have that uh, patient arrival to antibiotic time. So in that we say that within 30 minutes of arrival in a sepsis child, we'll have to start antibiotics. So ceftriaxone, doxy, and acyclovir in this scenario will be an apt choice, awaiting all the investigations. So just a clue of how to differentiate between dengue and scrub. Many times they come with minimal edema, thrombocytopenia, and hypoalbuminemia is almost always there in both the settings. Transaminase elevation is also there. So till we get our hands on our blood reports, the point of care reports, or in case situations where you really don't have the investigations, this happens in again in uh, primary care setups where individual doctor is there, they may not have the lab nearby to get the data. So in the absence of a typical HCAR, when you get a CBC value itself, a hemoglobin of more than 11 in this study there was a very high chance, 10 times chance that the child was having a dengue, and especially in association with the low leukocyte count. Whereas if the patient is having more of tachypnea, the counts can vary. It can be leukopenia or leukocytosis in scrub, but the patient is having significant tachypnea. The the weightage tends more in favor of scrub typhus. So there have been a lot of studies done in India and the other countries as well on undifferentiated fevers. So it is almost matching with the Velo data and the or local data. Scrub typhus is the most common febrile illness which comes in October to January season. So peaks somewhere around December and January here. So in an undifferentiated fever, it is almost always scrub typhus. You don't have to look out for a typical HCAR as well. Many times the HCAR is also not there, or it has the scab has fallen off that we cannot recognize it as a HCAR. And many a times, because the point of care testing or a scrub typhus testing has not been done, they come to us after 10 to 15 days. So the only clue will be a thrombocytopenia or a multi-organ dysfunction kind of picture which comes. So we are justified in starting doxy in our setup. In our area, so far malaria is less reported. So I'm sure as our present audience is all senior pediatricians and experienced pediatricians, so you definitely would have come across the Ishkar. And in our study as well, we found that this was the distribution. Almost 80% was in the hidden areas. So it is the routine practice for all the institutional postgraduates as well as doctors to look for, or we call it as comb for Ishkar. We just under the child and comb for an Ishkar across the body, and we encourage parents to examine them as well. So now let's come to the atypical clinical spectrum, because this is where the cases get delayed and there is some confusion over which specialty will take care. Recently, 1 week back also, we had a child with acute abdomen with clinical suspicion of appendicitis, posted for surgery. but then there was no conclusive evidence for appendicitis that, and it was under pediatric surgery, or it was under general surgery, that pediatricians picked up Ishkar, and we suggested that we do a scrub typhus as well. And scrub typhus test came positive, and then the patient was managed conservatively with the doxy alone. So it's very common for them to present as a simple fever with gastroenteritis as well. So even though respiratory is the most common presentation, sometimes they present with the vomiting and diarrhea as well. So cholecystitis has been diagnosed. There are settings where they are presented as viral myocarditis, or in adults as acute coronary syndrome as well. In our setup, cerebralitis kind of presentation where the patient presents with ataxia and nystagmus, that has been quite a few cases of CNS manifestations. Cranial nerve palsies are also be well reported. So we should look out for atypical manifestations. So this is the consolidated. I'm sorry if I'm just rushing up because we are falling short of time. Um, so a lot of patients come with kind of viral hepatitis picture, interstitial pneumonia, and as I said, cholecystitis or gallbladder wall swelling, uh, edematous gallbladder as commonly reported. So it is not to be mistaken as cholecystitis. And this edematous inflamed gallbladder is not specific to dengue. It's specific to scrub typhus. It is common in dengue as well, in enteric fever as well. Even in undifferentiated viral illnesses, measles also, we can get gallbladder swelling. So rarely it is presented as massive lobar pneumonia. So it has been reported in JIPMER, Indira Gandhi, as well as in our setup. Patient presented with bilateral or unilateral lobar pneumonia. So we sort of think that it is a typical lobar pneumonia or atypical lobar pneumonia, but probably an azithromycin for a atypical lobar pneumonia has changed the scenario. But in these three reported cases, as well as in other states where lobar pneumonia picture has been reported, documented ICD positivity or Weil-Felix text has been there. So in a child who is not responding to typical penicillin antibiotics, anti-penicillin antibiotics, we'll have to think of scrub as well. So these are the other presentation. Myocarditis being reported in Chennai, even as monoarthritis. Again, as I said, in children, the commonest presentation is of commonest meningoencephalitis in many places is scrub typhus. In our place, we most often say Japanese encephalitis, but now we can say with 50-50 hand that it is JE or scrub. So there was a report of bobblehead doll syndrome where child had typically come with nystagmus and titubation, that is head nodding. And investigation ruled out tumors or encephalitis. There was just cerebellar inflammation edema, and the scrub was positive. Child recovered beautifully with medication. So these are all the varied CNS manifestations. Even GPS kind of presentation has been reported. So just to be aware that even in a child with cranial nerve palsy or psychiatric manifestation or even ADEM, to look for an infective etiology, a treatable infective etiology. So, so coming to the recent updates with the point of care testing, like for typhoid, we are trying to, this is the tropical fever is not just a local problem, it is a global problem. So at the level of CDC and WHO, they are trying to find an ideal point of care testing where we can just diagnose typhoid, malaria, dengue, and scrub. So as these are common ones. Previously, IFT used to be the gold standard. Even now, by textbook, it is the gold standard. But then across the world, that is the Southeast Asia and including India, the IgM antibodies for scrub typhus has taken precedence because it is easy to do, less costly, and easily available. And among them, there are multiple brands which have come up with IgM ELISA. In our institute, we are following InBios. This is the US brand which is there. And this is one of the study published in India as well as in South Korea about the InBios technique. So as you can see, the sensitivity and specificity pattern for this particular brand was quite high. Uh, So for quite some time, we have been using the IgM ELISA card test for scrub typers, and we get the report within 1 hour time. So it is the decision making time is or the turnaround time is quite faster when it comes to dengue and scrub. So if this can be implemented or sensitized among the private practitioners by our IAP, so it will go a long way in reducing the burden of the disease. So lastly, this has been there has been just two publications based on the antibiotic responsiveness, that is again from South India. So there is increasing evidence of in Southeast Asia, especially in Thailand, doxycycline resistance has been quite rampant because malaria is also quite rampant, and doxy has been used as a prophylactic medication for all the tourists, military personnel. So there is ample evidence for doxy resistance in Thailand and Indo-China area. But in India, uh, doxy is not being much used. So there is a very good response to doxy. So there is a good fever control with doxy, whereas a poor or a delayed response to azithro. With with most antibiotics, we have definite guidelines to say this is the resistance, like a minimal inhibitory concentration of a drug, or we can have a in vitro studies for resistance. But when it comes to scrub typers, as of now, till date, even though a lot of studies are being undertaken, there's no concrete way of telling what constitutes as resistant or a delayed response. And delayed response is not just a drug alone; it is multifactorial. So in our study, after controlling all the variables, we found that doxy definitely has early advantage, better fever control than azithromycin. There's one more study which says that which reports a similar finding. This is in contrast to the world literature, especially from Thailand. In Thailand, it's exactly the reverse. So among the patients who had a rapid response to antibiotic within 48 hours, there was a significant difference. The children with doxy, only 8% had persistent fever, whereas 25% had persistent fever with azithromycin. So this area, I thought we